Hello. Nice to meet you guys. Oh, Dr. D's coming down the hall.
Oh, wonderful.
I think we're gonna have you guys meet in the classroom.
Which one?
Through here, but Charge is coming and
Okay,
Dr. D. So
thank you.
yeah,
How's your day going?
actually very busy and not. Your dad's sick. My other patient's very sick too. So definitely been running today. I'm like trying to catch up on charting, but
Do you have two patients?
yeah.
Can't handle any more than that.
Well, I kind of chose it. She had it split, and I'm like, oh, I had these two yesterday. I'm like, I'll just take them back. She's like, it's a heavy load. I'm like, oh, it'll be fine. But then the new Dr. D came on and changed up all these orders, so I'm like, running.
Hello, are you the Davis family?
Yes,
I'm Jamie, I'm ICU charge.
Hi, Jamie.
So Lindsay left for the day, she's our manager, so she just, I told her that I would meet with you guys.
Thank you.
So, did you wanna meet with Dr. Dernica first, or do you wanna go in
Yes.
the room, or how do you wanna do this?
Either way, whatever you prefer, because
Okay.
we'd like to do both.
Yeah, so, the room time, about an hour's visit. Okay, so after you meet with Dr. Dernica, I'll just kinda tell you, I'm not sure if Lindsay covered it all with you.
I'm not spoken to Lindsay.
Yeah.
Okay, so after today, starting Wednesday, he can have one designated visitor. So you can't switch out just one, so today decide who that's gonna be.
Okay.
So how are you related?
I'm his wife of
Wife.
47 years.
Okay,
I'm his daughter, it'll be
Okay.
her.
okay.
It'll be her.
So, starting Wednesday, you'll be able to come once a day for an hour visit. You'll have to get with us and let us know what time, we'll work with you on that.
Okay.
But while you're here, you'll have to wear all your protective gear. That's a mask, gloves, and a gown, okay? And it has to be on at all times in the room, okay?
Mhm.
And you can't go out in the waiting room and wait, so if you need to, you're only gonna get an hour.
Right.
So imagine you're gonna be in there for an hour.
Right.
But, if you needed to take a break, you have to go down to the cafeteria or, outside your car, okay?
Mhm.
This used to be a waiting room.
Right.
Things have
Things
changed.
changed.
So, we'll let
What
Dr.
if one has to go to the bathroom? Is there
There's a bathroom. This is our old waiting room.
Mhm.
It's just right around the corner there. And you can come back in, but, I'm limiting you for an hour.
Yeah. So hopefully I can hold it.
Well, yeah. There's bathrooms in the room, but you can't use that for
No.
infectious control, okay?
Mhm.
So,
But it's Monday, Wednesday, Friday, right?
yeah,
For
it's
visit-
starting this Wednesday. So I don't
It's
know.
Monday, Wednesday, Friday.
It's Monday,
Yeah.
Wednesday,
Okay.
Friday.
Because
Yes.
I don't know if they're gonna take them off isolation Wednesday or what the deal is, but starting this Wednesday.
No, I don't think so. I don't
Okay.
think I'm all by myself.
Yeah. So,
Okay.
anyway.
Well, we're grateful
Yeah,
for
well,
what we can get.
we've got a lot of COVID all around
I'm
here,
sure.
so you guys need to be really
We
careful,
will.
okay?
We will.
So we'll try to protect you and we're trying to protect us as well.
Yeah, we'll have you, are these your only, N95s or do you guys have more?
I have like 10 more.
Okay,
Yeah.
cause I was
We'll
gonna
always
say.
wear a new one when we come in.
Okay, because I was gonna say, we'll have you wear the face shield, the gown, gloves,
Sure.
along with that.
Okay.
We were just gonna give a regular mask, but if you guys wanna wear your N95s in there, that would be safer. And
I
then
like
just
it.
discard them and put a new one on when you're done,
Okay.
so. Okay,
I don't have an extra one on my way out of here. If you said discard them, like when we leave Dad's room.
When you leave here, we
Had a
can give you
regular-
one like I
Yeah.
have. We won't give you an N95 to wear out, because that's, we keep them for our active COVID.
Gotcha.
But like the ones I got on this is not an N95, this is what I wear all day.
okay, so,
Cool.
but yeah,
Thank you.
we'll give you those. Okay?
Alright.
Does Dr. D know that he's
I
here?
texted him, I saw him down there, I thought maybe he was coming, I texted him, but maybe, he didn't see it, so. I'll run down there and tell him.
Okay.
Yeah, ideally, I'd like to see him first, don't you
Right.
think?
That's
Kinda what I was
Yeah.
You want to?
Thinking, since it's
Okay.
already
Yeah.
5:15,
Well, yeah,
it'd be really
I
late
didn't,
before.
yeah, I didn't know
Yeah.
if he'd leave, so.
Do you wanna,
Yeah. Let me go ask him.
I can take you in here and, start the process here.
Okay, thank you.
Have you seen him through the camera, or you kinda know what you're gonna expect?
Yes,
Okay.
ma'am.
Sometimes it's kind of a scary looking. So this is his room. He's right now. I'm not sure what time Nikki will be back. I'm not sure why his blood pressure's up like that.
Is it 100?
Yeah, it might have been just a cuff thing, so.
Is it 100? I'm sorry, Jamie. Oh, 167 over 87.
No,
Okay.
really
That's what
check
it's
that.
been running.
I'm never sure what all the numbers are on the
Yeah.
monitors, you know.
It's got heart rate. His oxygen sats are 86%, and he is on 100% of oxygen. And I can't tell if that's 16 or 18 FP, but he is on 100%. That's as high as the ventilator goes.
Right.
He's also on Velitri, which is a medication to kind of help oxygenate his lungs. So he is on a lot of ventilator support, and his oxygen saturations are 86-87%. There's not.
He runs a normal about 88 because of his COPD. So he's kind of, and I was so.
Is he on oxygen though? Yeah. See, he's on 100% oxygen and only satting 86%. So he's probably with his COPD on room air satting 88%, which room air is like 21% at best. Unless you live next to a gravel road, but he's on 100%. He is on some sedation and I believe some fentanyl for pain, so they're keeping him sedated and comforted. And that's all I see from here, but I'll get you in the room here.
Okay, thank you.
This is Dr. Dernica here, so I don't know if you want to.
We want to talk with him first. Yes.
Hi.
Hi.
Sorry you don't want hi dear. How are you? I'm Dr. Dernica. Nice to meet you.
Nice to meet you. Thank you for seeing us.
No problem. What do you know so far?
I know he's in pretty dire straits.
Say
I
again?
said I know he's in pretty dire straits.
Yeah.
So, so you tell me.
Well, what we are dealing with now is ARDS, acute lung injury.
Yes.
That's flooding of the lung sacs with fluid and inflammatory cells and damage of the lining of the lung sacs. That's why there's difficulty with him, his ability to exchange oxygen, take oxygen and maintain his oxygen levels. So once you go into ARDS, particularly with the COVID, it's basically you support the patient, you do the prone, because when you prone patients, you can preferentially redirect some of that oxygen flow towards less sick areas of the lungs. So the oxygen level will go up actually with prone. Typically we do 16 hours out of 24 hours for 3 to 5 cycles, sometimes longer, depends on how patients respond.
When you say 3 to 5 cycles,
Which are 3 to 5 24-hour cycles.
okay, so he's been doing the prone for longer than that,
Yeah.
correct?
And
Okay.
that's not a good sign.
Yeah.
That means, the lung sacs are, severely flooded with, fluid and inflammation. It's a severe lung damage. You give steroids, but typically, steroids help during the initial phase of the illness, whether you go into more severe ARDS or less severe ARDS or less severe lung injury. Some do, some don't too. Even if you give them steroids early, they still can progress to severe lung damage. Otherwise, treatment is mostly supportive. That means, ventilator support, treat secondary infections. We just learned, I think, last 24 hours that he has a bacteria growing from the sputum
There is bacteria in this
called
lung.
Pseudomonas.
Now what kind of bacteria?
Pseudomonas, it's a bacteria.
Right.
So he's on IV antibiotics.
Okay, which kind?
He's on either cefepime or Fortes. I have so many patients, but
Right.
he is on appropriate IV antibiotics.
Okay.
And it's gonna be a long ride. I mean, with what we've seen with COVID, especially patients who develop severe ARDS, the average time on a ventilator is 20 to 25 days. That's the average time. Now, can be longer. assuming the best case scenario to, that, he shows some improvement in terms of his ability taking oxygen and weaning the oxygen concentration and the pressure and so forth. So that's where we are.
Okay. Do we want to talk about other treatment?
I don't know. I'm not sure what are you still using Decadron and?
He's still on Decadron, and typically it's 10 days course. We extend to 14 days in severe ARDS. Beyond that, the benefit is unknown. And what I've seen over the last 2 years, the longer you expose patients to corticosteroid, the more they become at risk for more infections.
More infections
More
with
More
cortico?
infection.
Okay.
Yeah, it's an immunosuppressant.
Right.
It decreases inflammation, but it does suppress your immune system.
Right. Is there a possibility to up the vitamin C for IV rather than through the tube, given that it's such low absorption through the tube?
We can give it. I'm not opposed. I don't think it's gonna help. I'd be worried about his kidneys with IV vitamin C.
Okay.
All these treatments, which are very, questionable benefit based on very limited data. And I heard some conversation between
Yes.
you and Dr. Lee. And I'm gonna mention them all: ivermectin, budesonide, vitamin C, vitamin D, melatonin, zinc. All these treatments, they were limited on very small pilot studies. Pilot studies means you take 30, 40 patients, there's no controlled arm, you give them,
Right.
some improve, some don't improve, but it's not compared. It's not what we call randomized controlled trial, where you actually compare patients versus placebo, double-blinded. You
Right.
don't know who got the medication, you don't know who got the placebo. That's how, you base your evidence-based medicine, whether a medication is effective or not. Now, all these pilot studies were done on outpatients. They were mildly ill with COVID. They were not the severely ill COVID. Again, once you progress into ARDS, lung injury, treatment is really, again, I'm going to say supportive, meaning ventilator support. Avoid further deterioration of the lung injury by providing what we call protective lung strategy, which is basically you don't want to inflate the lung too much because that can
Right.
perpetuate the lung injury. Treat secondary infections, nutritional support. Take it a day by day. If you give him higher dose budesonide, there is a good chance he might end with fungal pneumonia. Very good chance. Especially, what I've heard, you were requesting every 2 hours or 4 hours, I'm not sure. There's no evidence. Even, what we know about budesonide was very limited data and based on outpatient, mildly ill COVID. These were not patients who were in the hospital with severe ARDS in this situation. And I do not recommend adding therapies that are not proven because there is a good chance we might make him worse if we deviate from what we know or the evidence base we know. So it's gonna be a long road. There's no other words to put it, or kind of describe the situation in a better way, unfortunately. It's gonna be a long road for him.
Okay, so have you, well, look, you may need to step in. The treatment that Dr. Richard Bartlett has done, which he has done in hospital settings, and getting the budesonide into the ventilator.
Right.
And he's had success. Are you aware of that?
I'm aware of very limited data. There is no, again, and again, I suspect those patients were not ventilated severe ARDS patients because once there is severe ARDS, we know what's the pathophysiology. Budesonide is an inhaled steroid. It is mainly a medication for airways, not lung. If you want to look at the lungs, there are two components of the lung. You have the airways, bronchial tube, and then you have the lung sacs. The problem now is in the lung sacs. That's where the problem is. When you have all these lung sacs, flooded with inflammatory cells, and you already given IV steroids, I'm not sure what would you benefit from adding an inhaled steroid. In addition, it's not gonna we are at a point in the illness right now. Actually, when he came in, he was not in a good shape at all. That he was already in severe lung injury, and at this point, really treatment is ventilator management. That's really the key of treatment. That's really the mainstay of treatment. There is no medication you can give, even with the IV steroids that we're given, that's gonna make this better quickly.
Now, can I ask you if you, I know, I'm not a doctor. Not even a researcher. I've only done a little bit of looking. But I was watching a pulmonary, am I right? Nurse talk about how, it's best to be able to move them while they're on the ventilator.
Right.
Because that will help to, and so what do you, like move their arms and stuff. What do you think about that?
I mean, if we get to a point where he improves beyond this point, where we're not proning anymore, his gas exchange is better, that means he's requiring less oxygen concentration, less pressure. Yes, we're gonna need less sedation, and start making him, have him work with physical therapy. But right now, being dependent on prone ventilation for so many days is not a good sign. We can have physical therapy come when he's unproned and have them do range of motions. That would be okay. But again, I think, if this is the worst of it, I hope so. Because we don't have more room he doesn't have much reserve. Any other decompensation might take him down. I hope this is the worst of it. So.
We will be praying. We are praying.
Definitely.
It just seems so, like after all this time of you guys having to treat COVID, that there would be something.
Right. Unfortunately, like any viral pneumonia, because it's a virus and it's not a bacteria, they are difficult to treat. So even, I'll give you an example, other viral pneumonia, RSV, influenza. For example, RSV pneumonias, and if they end in lung injury, acute lung injury, there is no treatment. There is no medication you can give. It's just mainly ventilator support. Influenza, if you don't catch it in the first 48, 72 hours prior to, developing severe symptoms, Tamiflu does not work. It's a virus, that's the problem. Mm-hmm. And that's what, this is the problem with this pandemic. And that's how we are seeing, unfortunately, such a bad outcome with, all these infections. Because there is no effective treatment. It's a virus. It's not, a bacteria that you can contain. Pre-pandemic era, or, before COVID-19, we have bacterial pneumonias. We dealt with it all the time. We had viral pneumonias on and off. As ICU physician, I'll tell you, I prefer bacterial pneumonia over viral pneumonia. Viral pneumonias are very hard to treat. Now, this is pandemic time now, and we're seeing all viral pneumonias. Then we have secondary bacterial infection, which can make things even worse. But because it's a virus, unfortunately. Like, for example, the antiviral remdesivir, we give it, but in the ICU setting, we haven't felt it's a game changer. We still give it because it's the only evidence we have. There are some good studies done on it, and it's FDA approved now. But if not given early, before the patient get too sick, it doesn't seem it's very beneficial. So really the window, like Tamiflu for influenza, same thing with remdesivir with COVID, when you give it early, when patients are not on oxygen or just low flow oxygen, that's when they can benefit from the medication significantly. Once they get to a stage where they're requiring high flow oxygen or in the ICU, even if the onset of symptoms is within 10 days, like it is approved, we don't feel like it makes a whole lot difference, but we give it. But it's because it's a viral pneumonia. You want to target the viral replication, the virus trying to replicate and reproduce and infect more cells. You want to target early before it leads to this severe inflammatory response. The inflammatory response is dictated by the body. That's why some people get sick, some people don't get sick. And it all depends on, other, medical problems. But again, I promise you, we'll do our best to get him better. That's all I can tell you. We'll do our best. I'll do my best to get him better.
I appreciate that.
Thank you.
You're welcome.
I know you've been through a lot over these last few years.
No, it's okay.
I appreciate it. I appreciate your heart.
Thank you.
Thank you for letting us come up.
No problem.
Now the situation with, did we talk to him about the situation on the Monday, Wednesday, and Friday? What's the situation with that?
That's not under my control.
Yeah,
Okay.
back to the nurse.
Yeah, that's nursing administration. So I think what I heard Monday, Wednesday, Friday, 1 hour, one person at a time, or
One
Designated.
one designated person.
That'll be her.
You're able to video in, they
Yeah.
give you a code and you're able to camera in if you need to.
Yes. This gal's been great.
Okay.
So obviously we are devastated.
I understand.
Devastated. So we are interested in throwing everything at it.
I understand. But, honestly, you want to weigh the benefit versus the risks. If I give him budesonide every 2 or 4 hours and he ends with fungal pneumonia, we have no room to
Work with that.
work with it.
Yeah, yeah.
We're barely there. On top of that, he has Pseudomonas pneumonia, so given an inhaled steroid in addition to the IV steroids, there is no compelling or strong evidence to say, yeah, that's it, let's do it. Unfortunately, it's not. He's already on some budesonide, by the way. Dr. Lee has put him for COPD, which is fine, which is the adult dose, which is, just adequate. But
Right, it's not the ARDS dose.
right. I never give it in that dosing. By
You
the
don't
way.
give it in that dosing for ARDS?
No, not at all. In fact, even there are some reports that breathing treatment, albuterol, can make ARDS worse. There are some, not in COVID, your ARDS in general.
Okay.
But you always go by evidence-based, and all these years with management of ARDS, there is one thing that proved to improve survival is mechanical ventilation, a ventilator, and what we call low tidal volume ventilation, which is basically protect the lungs from hyperinflation. These lung sacs are flooded, but there are other lung sacs that are relatively more healthy. If you give too much high volume from the ventilator, you can overdistend the healthy
Yes.
lung sacs and make lung injury worse.
Right.
But that's really the only evidence. Even IV steroids outside COVID for ARDS, very questionable. Very, very questionable. And it's not endorsed or recommended. We do it sometimes when we ran out of options. Like, for example, the RDSD bacterial pneumonia, other viral pneumonia like flu and so forth. We just don't do it. The IV steroids came mainly during this COVID pandemic, actually.
You probably are aware. Probably are aware that our nephew is the prophet that died of COVID. And so we want to do everything we can to speak.
Well, and when he came in, he's very frightened. I mean, the
I
television
heard.
every day tells him he's going to die if he goes to the hospital. So,
And he wanted me to, and I promised him I'd be by his side because he knew he was in bad shape and we knew he didn't have to. I mean, we just whatever. And I appreciate your support. I appreciate your time. And I really don't know why I told you all that stuff. It's just that,
we're not giving up.
yeah.
We're going to pray.
And as I said,
pray over it.
as a staff here, doctors, we promise you we're doing our best to get him better. We're not in a good position, but we'll do our best to get him better.
Okay. You do your best, and and we'll be flooding heaven's gates with prayer.
Okay, very good.
And between you guys and God, we're going to have
Hang
hope.
in there.
Yeah.
As I told you, it's gonna be a long road.
I
It's gonna be a long road.
I can handle a long road if I can get him home.
Yeah, well, I mean, that would be amazing if we could get him home, but that's a huge hurdle, even I meant for home health or hospice even, so that's a huge hurdle, isn't it?
Yeah, but you know, just what we've seen over time, that a patient remains dependent on the ventilator for a long time. What happens during this time, because of sedation, you need heavy sedation when you need high ventilator requirements to be able to be synchronous with the ventilator, have effective breath and ventilation to the lungs. That even after, you know, improvement in oxygen and weaning oxygen, patient don't wake up, you know, the normal way, because were sedated for quite a
Right.
long,
Yes.
and they become weak too.
Right.
Yeah, and often we had patient with a trach and, you know, discharged to a long-term acute care facility and rehab, and we had really beautiful success stories, and I'll stick to that. And we'll just, you know, take it a day by day.
Now, we're concerned obviously about the fentanyl load. You've got 200 currently,
Right.
and we'd like, you know, obviously that's a paralytic or a pain, and then the other is a paralytic, so.
We don't have him on systemic paralysis, but we had to give him one push of a paralytic today because of desaturations as the oxygen was going lower or trending lower. But fentanyl is an opioid, and the other one is a sedative, but you know, he's not on full systemic paralysis.
He's not full. Okay. Okay. We're worried about.
Yeah. So you see the
heart.
white stuff is propofol. So that's considered sedative.
Okay.
And then you have the fentanyl PCA just below it, actually, down, all the way down. Well, we have to push once today, and that's.
Now, do you have his records from VA?
I don't.
Would
I
you?
did look, but there wasn't very much that actually pulled over.
Is this when he showed up to the ER? Or?
Well,
We don't have him.
he's also a VA patient,
Mhm.
you know. So, and he's been, I mean, they diagnosed him with, you know, COPD a while back, but they hadn't put him on oxygen yet. And then we went to VA on Monday night because he thought they'll just give him some oxygen and send him home. You know, that's what he thought. And I mean, and as it turned out, they were able to, they were shocked actually, that they were able, because he was so bad when we came in, they were shocked that they were able to get his O2 to stabilize, you know, because they didn't think they could. And, but they were able to get it to stabilize. And then we sat there in the emergency room all night long. And then we went home, and because I wanted to give
Yeah.
him the monoclonal antibodies.
Right, that piece, yeah, I was
I-
informed about.
Yeah, I felt like that, because, you know, once you get in the hospital, I was told you can't have monoclonal. And so we took him and got him the monoclonal. And then,
Which monoclonal he got? That's the question. Do you know that they give him sotrovimab, or because we know the monoclonal that we used to use for the Delta is only 40% effective, and there is another monoclonal that is not widely available. It's very hard to find. It's called sotrovimab. So do you know which one he got?
So what's it called?
Sotrovimab.
No. Did he get?
I
Do you have paperwork on it?
can,
We can find out and
Oh,
send it to
okay.
you.
Yeah,
Say I
you
can-
can just let me know. I
Okay.
would just would like to
yeah,
know.
Yeah, for sure.
I'll text his, the lady that did it. She's been keeping in touch.
Now, you mentioned that about that patient or whatever, that they weren't as bad off and maybe didn't have ARDS, but the husband of the patient was being contacted constantly, and they were asking him if he was ready for hospice. So it was it was not good. I don't know that she had ARDS necessarily, but it was not good. And they, after a meeting, they upped the budesonide, and she instantly responded within a day's worth of that Q4H. So, you know, we're just wanting to try anything and everything. And I know that's anecdotal.
Right.
I handed Nikki a study on the budesonide for ARDS or COPD for difficult to wean patients off of the vent
Yeah.
by Dr. Saeed, I think. So, thank you.
Yeah,
Yes,
I
it
think I'm aware of this.
You
study.
might be, yeah, it's pretty popular. So, is there a way we could just try it for a day and then titrate back if you weren't happy with any results?
Right, but this is a different context. Yeah, this is not, you know, this is respiratory failure due to exacerbation of COPD. So this is again an airway issue.
An airway. not the-
COPD is an airway issue. Again, the lungs are bronchial tube and lung sacs.
Okay.
So it makes sense, you know, high dose budesonide because the airways are the main issue. When you have COPD or asthma flares, you know, patients go on a ventilator for that reason. But the lungs itself, they not most of the time they're not an issue. Instead, straight COPD flare, it's an airway issue. So yeah, you can give breathing treatment, you can give high dose inhaled budesonide, but this is not ARDS. ARDS means if you do biopsies of patients with ARDS, it's diffuse alveolar damage. So basically, you have the lung sac and the whole lung is moving. Lung sac and a vessel. That's what you want. So there's a million units. Millions and millions. What happens with the lung sac here is so inflamed that the barrier between the lung sacs and the blood is impaired or ruptured. If you will, that doesn't do what it's supposed to do anymore. So you have a flooding of all these inflammatory cells. That empty space between the lung sac and the vessels into the alveoli, the lung sac. And it floods. When it floods, you cannot take oxygen. It's not an airway issue, this is a lung sac issue. And in particular, budesonide with COVID were first studies. But these were mostly outpatient. These were patients with mild symptoms or moderate symptoms of COVID. They were not in ARDS.
Peer-reviewed evidence exists for use of budesonide in ARDS and ALI for patient with secondary diagnosis coded for either ALI or ARDS. Nebulized budesonide is within the standard of care to treat the condition. It's in this right here. Effective nebulized budesonide on respiratory attacks. I've emailed that study to Nikki as well. I mean, you're the pulmonologist.
Right.
I'm just a person who cares about her hero daddy.
So is this published study or is peer reviewed?
I'm not certain.
It looks like peer reviewed.
Okay. Obviously, it's from
So
PubMed.
reviewed.
Yeah.
Let me just take a picture of it.
No,
I'll just,
you can have it. Well, oh, okay.
There's something on the back of it.
No, it's
I'll look it up.
Thank you.
Thank you so much.
There's a few if you want to take all these blue. Just a couple there. Stoic
Right.
study may not be.
Yeah, I'm just interested in the ARDS. I mean, we do use nebulized budesonide for other indications, but I'm mostly indicated for the ARDS.
Yeah.
See what the contest, but it looks like it's peer reviewed. So I wonder if this is published or not published yet. I don't know.
Okay. Okay. Appreciate you.
Yeah,
Okay. I'll bring her up here, but I won't come in.
Okay. All right. Nice
I
to
want
meet
to
you
tell you
too.
that Dr. Jeff Craig
Yeah.
gives you a high recommendation.
All right.
So, thank
Yeah,
you.
thank you so much.
Okay.
All right.